Thank you. So it's the time to start the international session, and today is the 1765th day of uninterrupted daily webinar of IFPH. Before beginning the session, let's have a silent prayer. Hello, doctors, students of homeopathy, and friends of homeopathy. Wish you all a happy Doctors' Day. Today is the 1765th day of uninterrupted daily webinar of IFPH, and today our guest is Professor Dr. JYOTI Kalantri, Professor and Head of the Department of Obstetrics and Gynecology, Tagatmal Sri Vallabha Homeopathic Medical College, Amravati, Maharashtra. She is also the Chief Consultant at Homeopathic Specialty Clinic, Amravati. She do have more than 25 years of clinical and teaching experience, following classical, that is Hahnemannian homeopathy, doing a lot of research projects, published several articles creating awareness on the principles and practice of homeopathy. And today's topic is a clinical study on vulvodynia and efficacy of SIMILIMUM in homeopathy. Let us welcome Dr. JYOTI. And I welcome you all for the session. Doctor, let's start.
Thank you, sir. So, good evening to one and all my respected seniors and dear friends. First of all, I am feeling very privileged to once again deliver a seminar in English on this topic, that is vulvodynia. Sir, I'm audible?
Yes, yes.
Yeah. So, vulvodynia is vulval pain syndrome. That is pain in vulva. So this is, everyone knows what is vulva. It's an external genitalia. Let's have a quick review again. What is vulva? It is a gynec area. It's an area in gynec practice, which is comprising of whole of external genitalia. We can see the openings, two major openings, that is urethral opening, vaginal opening, can we show? So clitoris, outer pad of fat is labia majora, and then two thin folds, labia minora, then hymen, and two openings. Again, two openings are there, which are of Bartholin ducts, which opens inside the labia minora, which are coming from Bartholin glands. So this is vulva. Then what is vagina? See, vulva connects vagina internally. Now, vagina is a fibromuscular flask-shaped canal which connects uterus as well as vaginal introitus. So in vulvodynia, we can see pain only at vulva or at the vulvovaginal junctions. So we should know properly the anatomy and physiological functions of vulvovagina. So what is the definition of vulvodynia? This is nothing but the pain. It can be chronic. It is initially acute, but it is chronic, unexplained pain in the vulval area or at the opening of vulvovaginal junctions. So pain is constant or occasional. Pain may last for a few months or years. So this disease, see, causes are already prevailing since long, but this disorder is being invented, or we can say studied in the year 1991. It was discovered that this is a pain where sometime you may find cause and sometime you may not find any cause. So on examination, most of the gynecologists or we homeopaths or any other pathy doctors will see perfectly normal vulva and vagina, nothing abnormal is detected there. So this pain is most of the time considered as psychological on the part of the patient. So in 1991, it was seen that since it was diagnosed, now it has been increasing speedily in both the age groups of female reproductive life, like puberal girls and perimenopausal girls. And of course, maturity age group of women are also suffering equally. So this topic I have chosen nowadays. I can see a lot of patients I have seen of vulvodynia in all age groups of the female from puberty to perimenopause. So to make aware of this study, thank you for giving me chance. So we will, once definition is over, now pain can be constant or occasional. If occasional, so long as it is acute, it is occasional. But if it is not being treated in time and when it becomes chronic, the pain becomes constant. So we will have a quick look to the etiologies. Etiologies are irritants. Then allergies to certain creams, certain perfumes or perfume tampons, like sport girls or celebrities or many girls prefer tampons, so that perfume tampons may cause allergic reactions. Of course, some objects which are used. Then hormonal imbalance. Now, women, those who are taking OC pills or those who are breastfeeding their babies, there is deficiency of hormone estrogen. And of course, those who are having already hormonal imbalances at the perimenopausal age group may have dryness, may have itching in the perimenopausal age group of women. So estrogen deficiency is important cause, which I have seen. Then psychological. See, most of the doctors say this, it's in your mind. There is nothing abnormal detected. So you just relax. There is no pain. But I have seen patients who are literally crying and who are asking that, can I, will I be able to live my normal life? Although a married woman will say, will I be able to consume my marriage properly or live a married life or not? They are, because it develops so much fear and anxiety. So psychological causes, we can also see anxiety disorders cases suffers with this a lot. Those who are having fear of attempting sex, like in married women, and guilt, a sense of guilt. Those who have been in illegal relationship, the sense of guilt, that is again causing a trigger points in her vulva vagina. So that is important psychological disturbances which I have seen. Then organic diseases. This is very common, like infections. Pelvic infections may be bacterial, may be viral, may be parasitic. In viral, we have seen human papillomaviral infections as well as herpes infections are common. See, Gynec Society, All India Gynec Society has declared that 75% of the women suffer with fungal infection in their reproductive life, anytime with fungal infections as well as dyspareunia. Now, what is dyspareunia? It is painful coition. So infections is most important again, but always you will not find it, HPV and herpes. But of course, when we have to exclude vulvodynia, we have to go for all these investigations, swab test, HPV infections, even pap smears in maturity age group of women. Now, most important, another cause we have found is pelvic floor muscle tension. Here, pelvic floor muscles get stiffed. There is tension. So most of the cases we see those who have surgical interventions, some procedures, and even in unmarried girls, which cases I have seen is surgical abortions before marriage. Now there is trauma. That injury to the pelvic floor muscles, instrumentations and all may cause muscle spasm. Now, what exactly happens, we will understand. There are inner muscles of the pelvic floor are inside the pelvis and outside perineal muscles are there. Now, if there is injury and spasms occurs in both superficial as well as deep muscles, that spasm causes contractions of the nerves and the nerves get irritated. These irritated nerves causes trigger points at the vulva. In between that spasms and irritations of the nerves, muscle blood flow also reduces. So all these things works together and then patient gives you trigger points where there is pain. Now these trigger points, if they are acute, it causes occasional pain. But when it becomes chronic, it gives a constant pain. This is the reason why some women face occasional pain and some have constant pain. So constant pain is chronic condition and it is very difficult to for her, it is very difficult to lead her normal routine life. And autoimmune diseases, most important, here it is not mentioned. Now, most of the autoimmune diseases like rheumatoid arthritis or lupus, they causes cell damage. In these cases, vaginal cell get damaged and the damaged tissue get weakened, and weakened tissues again causes, gives a pain and weakness of the pelvic floor muscles. Last is urinary oxalate burning. The women who are having urinary infections, if they are frequently urinating, then they may cause frequent burning. They may have frequent burning at the urinary area. One terminology, that is vestibulitis. Name itself suggests it's an inflammation of the vestibule, which is a diamond-shaped area at the vulva where 4 openings are there. It causes pain and swelling. So if we touch that area, even if we are not touching, sometimes we can see the erythema in the vulval region. And this causes superficial dyspareunia in reproductive women. Superficial dyspareunia means when an attempt of coition is done in the beginning. Then one more thing we can see, that is diastatic vulvodynia. Diastatic is related with skin, cutaneous. Here we can see there is non-localized vulval pain. See, vulva, patient even cannot tell us where exactly she's having pain. So non-localized vulval pain, which is unprovoked sometimes. There is no reason why she's having pain. She's sitting and she's walking, she's having pain. So it's a constant neurological pain in vulva as well as perianal region. So very much sensitivity is very much increased. In this condition, perimenopausal age group women may have burning as well as dyspareunia, painful coition. Then psychologically disturbed and anxiousness is very much marked in these cases, that women keeps on telling, will I be able to lead a normal life or not? And they are very much worried of marital disharmony. In these cases of diastenic vulvodynia, we see a lot of cases are going towards the breakdown of marital relationship and another next marriage. So this is really a dangerous condition. How can we diagnose? So we have to take detailed history. First of all, medical history, then history, sexual history, psychological history, of course, emotional history, social history, surgical history. So all histories are to be taken care of properly, should be interrogated. Recently, any abortion, any surgery, any instrumentation like DNC and all this may affect to, if not all, but few of them may suffer with such previous instrumentations or surgical procedures or some psychological trauma. Of course, the history is very important. Then after history, local examinations. Of course, we will have to go for temperature, pulse, respiration, blood pressure, general and systemic. Then gynec point of view, we will give more importance to local examinations, pelvic examinations. So visual genital examinations or signs of infections and other causes are to be seen. Here, after taking all histories and examinations, one have to go for a swab test. Swab test is nothing but a test where cotton wool is dipped in water and it is applied on particular areas of the vulva to find out the trigger points. So trigger points we want to know. So if patient can explain us, so we will find if she can show us, we will find the tenderness on her face on that particular area, like 10 o'clock or 12 o'clock is the commonest area where we will find vulval pain. We usually keeps on finding. So pelvic examination and cotton swab test is important in this line. Then we will have a quick again review for vulvovaginal symptoms. Patient may have a constant pain. She may have painful sexual intercourse. She may have painful prolonged sitting. So sitting also becomes difficult for her. Walking to difficult hoga hi hoga, but sitting also. And what we can say for other activities, they are again more difficult, like biking, cycling, dancing, everything. So painful tampon insertions, many girls comes to us and say it's difficult for us to use tampons and menstrual cups. Pain in wearing when wearing fitted pants, so she cannot even wear clothes of her choices, always loosen her clothes, and irritating, burning and stinging pain occurs. Now, what about treatment? First and foremost is lifestyle changes. If she is using tampons, perfumes and all in that area, we will ask her not to use perfume tampons that may cause allergies, not to apply any ointment, allergic reactions may occur. she should wash her area with normal water. No marketed products like V-wash, antiseptics are not required, just gentle wash and no frequent washing also of that area. Then exercise of pelvic floor muscles is important for those who are having pelvic floor muscle stiffness. One should avoid hot bath. Vigorous activities like biking, cycling, horse riding for active patients of vulvodynia. Yes, one can go for cold compresses uses and supplementations like magnesium, probiotics, and multivitamins. Here, magnesium deficiencies association was found. So supplementation of magnesiums may help to the patient, and ointments. Of course, ointment can be given. Here, oral medications. See, any pathy will give oral medications, but we have to give oral medications depending upon the history and all about her investigations and what we will do, the totality of the patients. So ways to reduce, again, check to see if some foods like caffeine, sugary foods that increases her symptoms, ask her habits. She should cut short these habits. Then loose clothes, these are lifestyle changes, and then avoid toilet papers and washing powders with chemical irritants. Then bath with lukewarm water, not so hot water. Dry the part gently. Try a vaginal lubricant before intercourse. So this is all about lifestyle modifications. One more thing, that is biofeedback therapy. Here, biofeedback therapy means pain management, which has been come in existence. Those who are unable to bear, they finally opt for that biofeedback therapy, but that is also temporary as per my knowledge. So a case presentation I'm beginning with. This is a case of a woman aged 39 years, married, named Mrs. Sawant. So she came with complaints of burning pain at vulva since 6 months. And she complains of pain ऐसा कि acid डाले जैसा, such a burning pain and pricking, piercing pain, which is aggravated by hot water and ameliorated by cold ice packing. So her history of present complaints, pain starts in the morning and disappears at night. She used to tell us, मॉर्निंग में पेन बढ़ता है, रात में कम होता है. She slept normally because of no pain at night, but otherwise I see most of the patients suffers with pain at night also, but in this case only in morning. She took all kind of medications, pessaries, ointments. When she consulted, she took 4 gynecologist treatments. Some told her fungal infection, some told her nothing is there, it's in your mind, some told her psychological. So all investigations were already performed in this case. But she gave me the history that this case is of at the time of COVID. So death of family members due to corona, and she was very much stressed because of her nearby members' death. Her associated complaints were hyperacidity. Then she had to vomit by irritating herself by mechanical removal. And she also complained of nervous diarrhea whenever she have to attempt or appear in public or some speeches and all somewhere. She'll have to pass her motions. That is nervous diarrhea. Her past history showed PCOD, acne, hair loss, and for the PCOD, she has underwent laparoscopic investigations before her marriage. Her family history was diabetes mellitus, myocardial infections, paralysis, hypertension, GB stone, again acidity, vicious suffering, and ulcerative colitis. So we can see almost psychotic disorders prevalent in her family. And menstrual history, she used to have normal menses, regular time, but dark flow, heavy flow for 5 to 6 days, and normal primary dysmenorrhea she was having. Her obstetric history, full-term normal delivery, male child of 12 years, which was normal at the time, the thermals. Now, she was giving the history of suffering from both extremes of heat and cold, but towards what? Extremes of heat and cold, but most of the time suffers with heat. So when she was examined in my OPD, on examination, there was painfulness on speculum insertion. Then tenderness found on cotton swab test. Cotton swab test at V10 and V2 positions. We can see V2 and V10. This is clockwise positions. So cotton swab test showed tenderness on her face. Then coming to her personal history after examination, her build was average. First was normal. She desired sweets 3+, milk and curd. Okay. So sweet desired was very much. She used to tell me that I used to have directly sugar if I get a desire for having a sweets. Aversion, sad things. Sleep was sound. Dreams of snakes. She dreamed of snakes are attacking on her body and she is defending. So she also dreamed of her dead family members and alive members at that time because she was in panic situations due to corona also. So stool was, she was having nervous diarrhea. I have already told you sweat on scalp, which was profuse sweat. And of course, sexual history was unsatisfied because unable to perform the position due to pain. Her mind was active, intelligent, curious. She used to tell me, मैंने सारा Google search मार लिया, सारी किताबें पढ़ ली. I have gone through every literature, but I'm not getting actually what I am suffering. I have seen lot of gynecologists. They are not telling me what exactly is happening. I think normal है, fungal है, UTI है, UTI investigation करा लो, UTI medicine दे दो, fungal medicine दे दो. But I'm not getting relief, madam. So she was very intelligent, what I have considered, and curious to know kya ho raha hai, kya nahi, reading everything and all. Talkative she was. Anxious about her disease, very much marked. It's very natural in these conditions, but anxiety. Unusual and long continued mental exertions. She used to exert for this situation also, what is happening and what is not. So fear of disease and recovery. This fear of recovery was there in her mind, which was constant at every visit I have found. So investigations, we will have a quick look that blood glucose and vitamin B12 investigations here. See, I have seen also her USG report was not showing any other abnormality related to vulvodynia, but we have seen left ovarian simple cyst. It is not PCOD. It was a simple cyst which we see some or other time in women's or girls, and it may subside by itself. So no obvious signs of any ovarian torsions or any these cystic torsions, but left ovary, little bit cyst was there and no torsions, nothing abnormal. So nothing, no such abnormality was found related to our disorder. Then her urine culture, urine routine, it was normal so far at that time. Only occasional epithelial cells were found in this condition. So this was the case. Investigations were done on March. Can you see the date? In November 21. All investigations were performed in 21. Then we will have to exclude other pathologies. So vaginal swab test was done. Vaginal swab test, nothing was found but swab when investigated under microscope. Budding of yeast means a past history of fungal infection was to some extent was found, just a budding. So her microscopic report shows nothing abnormal, but gram-positive bacilli. Means it was not like any inflammatory cells which is suggesting PID, serious PIDs or any pap smear abnormalities, but it was just a gram-positive bacilli which was suggestive of lactobacilli, and few burdings of yeast fungal infections were found. Now, rubric selected by me were, depending upon her mental generals, physical generals, and particulars. Mind, anxiety, concise. Anxiety. Concise means she don't know whether her mind says whether right or wrong. She is thinking right or wrong. That is concise anxiety of. Anxiety of health about. And mind curious and mind intelligent. Head was cold water, always When she was having headache, she used to say that cold water or cold bathing ameliorates her. Perspiration of scalp, which was profuse. Female genitalia, sex pain, piercing. Female genitalia, sex pain at labia, which is between labia, stitching pain. Female genitalia, pain, vagina, burning. Dreams of dead relatives. Then dreams, snakes. Generals, cold ameliorates. Generals, food and drinks, milk desire. Generals, food and drinks, sour, food, acids, aversions, and generals, food and drinks, sweet desire. Sweet desire. So, as we all know, most of the time in repertory, we see sulfur very commonly comes in at the first rank. Same is the thing here. Sulfur ranked first, then calcarea, lacasis, natrium, phosphorus. After this repertorial totality, sulfur was prescribed 204 doses, BD for 2 days, twice in a day, which was followed by Saclac for 1 month. Then her first follow-up was on 16th of Jan 22. She was in medicine on December 21. Her complaints were a bit reduced. We can say just 20 to 30% for a week. Initially, sulfur has worked so well. Then she gave a new complaints like acne. She was not having acne, but those were aggravated. Her menstrual flow was bit normal and pain was bit normal, which we were not bothered about, but she told. Acidity and nervous diarrhea was reduced to some extent. And at this moment, I have on her first follow-up, because we know sulfur is acting for 1 or 2 months. So we need not to give any other medications in between when it is working. I have given just a biochemic medicines, Ferrum-Phos, which is indicated in our biochemic books, like for subacute inflammatory stages and subacute infections, inflammations. It's a very good remedy. So biochemic was prescribed, Ferrum-Phos was prescribed 5 tablets for about 3 times a day continuously till the next follow-up. Second follow-up on 21st of Feb 22, her pain was reduced. That is after 2 months approximately. Then pain was reduced, but still burning, itching, and piercing was on and off. Here I have advocated sulfur 1 m, 3 doses, OD for 3 days. So, and it is followed by Saclac. And on third follow-up, that is on 24th of March 22, see, we can see after approximately 1 month, her burning pain was reduced to 60% and acne 2 to 4 just appeared on her forehead. Pain at few points. If we have applied a swab, aggravation by pressure, it was at just few points. Matlab, initially was also, it was at 3 to 4 areas only. Now it has reduced to 1 or 2 areas. At this stage, she was so much worried. Madam, ye kabhi jayega bhi ki nahi, my pain. So some people are advising physiotherapy. So I am thinking that I should opt for physiotherapy. At that time, I am not interrupted her. I asked her, yes, you can start physiotherapy. It's a supportive medications for pelvic floor muscles, which might have got tensed. So it will help. And here I have given for her hyperacidity was increased. So argentum nitricum 200, which follows. These are complementary, argentum and sulfur. For her conditions like nervous diarrheas and hyperacidity, it was introduced. Unfortunately, sorry, was not mentioned in slide, but argentum nitricum was given only for hyperacidity conditions, and only 1 dose was given, which is followed by again Saclac. Fourth follow-up on 8th of May 22, her pain was reduced to 80%. She was much better generally. Her anxiety was relieved anxiety was relieved a lot. And at this point, she was just telling ki, ab ye, I want to get rid of this. Pain is occasional. Anxiety was reduced, but piercing was there. If she is doing her activity, the piercing on and off was increased. So sulfur 10 m 1 dose was advocated with lifestyle modifications. Now her 5th, 6th, 7th follow-up was that she was very much better generally and physically. It is very hard to mention each and everything. She is reduced to 95%, and she was very happy patient. Treatment was further continued for Ferrum-Phos and Saclac. Now, why we can think of sulfur? And here the miasmatic study repertory and of sexual symptoms was studied. See, many of the cases of vulvodynia, my study showed that sulfur is some or other time you will require. Initially, suppose, see, when can give sulfur if we see literature, when acute condition is not recovering, suppose it has stopped the growth, at that time we can complete the cure. If in chronic conditions, we can begin with sulfur. Suppose some medicines, well-selected medicines have acted, but has not brought a cure of that level, again, we can think of sulfur. If we see boric materia medica, so that is a very good antisoric remedy by our master Hahnemann, which is helping us throughout a lot of cases. So again, we will have a look at miasmatic repertory of sexual symptoms. What is the role of where this vulvodynia symptoms can be comparatively kept in psora, psychosis, syphilis, tubercular, and mixed miasms. See, pruritus, first symptom pruritus, burning comes in psora, and of course, mixed miasms will cover. Voluptuous burning. Then aggravation by meat. Pruritus with meat aggravations is seen in psychosis miasm. Then sexual organs is seen in again a psychosis miasm. Vulva complaints or pulsations in vulva, again a psychotic miasm. Pain, urinary pain it is, pulsating, stitching pain, again a psychosis miasm. Burning, burning by change of weather. By change of weather, psychosis miasm, and burning by rest, psychosis miasm. Sexual symptoms which are aggravated by cold, psora, and amelioration by warmth. If we see sulfur, sulfur is again which aggravated by heat of bed, but relieved by warmth also and cold application also. But here sexual symptoms of, we are talking about sexual symptoms miasmatic repertoire. Now, what is the miasmatic weightage is given to sulfur as far as miasms are concerned? Psora is given 3+, psychosis 2+, syphilitic symptoms are found 3+. So, if we consider psora and syphilis, we know pseudosyphilis is a tubercular miasm, and tubercular miasm, in this case, we have seen some or other past history of disorders and frequent infections. So tubercular miasm is found in this case also. So psora, syphilis are prominently seen in sulfur, and of course mixed miasms. So this is all about miasmatic repertory and miasmatic weightage of sulfur. Now, what is the role of sulfur in this condition? It is having a prospective role in treatment of vulval pain syndrome. Homeopathic treatment is based on personal history. See, all of us know that we have to take detailed history. All in this condition, emotional, psychological, social, medical, and of course, emotional history and past marital history, marital disharmony is also to be understood. Sulfur can treat vulvodynia effectively. How? By desensitizing, by calming the precipitating factors, thereby supporting pain management. So it calms the irritated trigger points and supports the relieving of pain is relieved. It also supports immune system. It is mentioned in boric materia medica for autoimmune disorders and bad effects of autoimmune diseases. Sulfur is best medicines we can begin or end with. It decreases the symptoms, including pain of varying types and degrees, and calms the turmoil in both brain and body. This is mentioned in our literatures. What is the role of sulfur? So I think there should not be any confusion why sulfur is acting and treating vulvodynia cases. In many cases, I have seen I should begin with, or I should give as an anti-miasmatic, or I should end it with. So this is a great remedy by our master Hahnemann. So sulfur have great soreness. We will have again symptomatology here. Great soreness in vagina and vulva. Vaginal discharge are yellow. Again, whitish also, sticky, yellow, burning and excoriating. All the orifices are red, and red. Face is also flushed. Redness we can see on the face of the patient. Sulfur patient's vagina complaints, pain in the vagina are aggravated by positions. Itching is increased in vagina. Thermally hot patient, thirsty patient, And desires of foods of sulfur are beer, whiskey, alcohol, or stimulants, raw food, sour, spicy, of course, sweets. So somewhere if a patient is on very much stimulants, you can say indulgence of alcohol and all, this is affecting somewhere their vitality. And sulfur is arousing. It is written in our Materia Medica that when it is advised, it arouses the vitality and it refreshes the actions. So where food aversions, meat and olives. What are the general aggravations of sulfur? Standing, bathing, rising, before menses, even sitting. And vulvodynia patients are, of course, aggravated by sitting, motions, general ameliorations. General ameliorations are by discharges. So this is all about sulfur's role. Any queries at this point? I have ended with first case. Chat box. Chat box. Should I begin with another case?
Yes, let's continue.
Okay, sir. Thank you, sir. One more case, which is again a woman of reproductive age group, maturity age group, that is Mrs. Gosavi, who was married. Her present complaints were piercing pain at vulva since 3 months. She came with piercing pain, ऐसा कुछ चुभे जैसा लगता है. So much pricking was marked and burning at vulva on and off, aggravated by sitting, walking, amelioration by cold and rest. Incompetence were again hyperacidity, which is relieved by vomiting. Her history of present complaints was pain radiated all over vulvular region, which is aggravated by sitting and ameliorated by rest. She had PID when she was pregnant. She delivered baby recently. She had, and her baby was of I think 6 months at that time, and she had pelvic infections when she was antenatal care ANC patient. She took all kind of medications, pessaries, ointments. She took gynec treatment. She got relief for some time, but then complaints again reappeared. Her past history was obstetric history was she was having full-term normal hospitalized delivery cesarean section due to cervical dystocia. She had a male child, of 1 year, and breastfeeding was continued. This was the important history. After 1 year also, 1 year, she was still continuing, and I asked her to, now she can stop the breastfeeding because this may cause hormonal imbalance. We have seen the cause, deficiency of hormone estrogen. Her past history was acidity 3+, acid peptic disorder, hyperacidity she was having. Now, she was having typhoid recurrent 3 times before she came to me. Then hypotensive, she was having low blood pressure and soles, heat in the soles. And palms was 1+, but soles was 3+. Her family history was only hyperacidity. In her parents, grandparents, everyone have hyperacidity disorders. She was lean and thin physically. Her menstrual history was regular, normal. When I took her case, her LMP was 11th Jan 2025. Thermally, she was ambithermal towards hot. She liked rainy seasons. She was ambithermal, and sun heat or summer causes headache on vertex. So ambithermal towards hot. She was unable to bear the summer or sun heat. Her personal history was built was lean, thin, with soft wart on her face. Appetite was normal. Thirst was long quantity at short intervals. She desired sweets, very much desired for sweets again. Aversion, not any particular. Sleep was sound. Stool were unsatisfactory and with flatulence. She used to pass for 3 to 4 times in a day. Urine was normal. On examination on her vulva, skin looked totally normal. Localized pain on pressure was elicited at some points. Just a cotton swab test to some extent, somewhere it was, she was showing severe pain, but skin was totally normal. Her mental symptoms were she was having anxiety, nervousness, suppressions of emotions. Now, what kind of emotion suppressions we'll discuss? Weeping dispositions due to illness, trifles, and consolation ameliorates her. Desires for company. She was fastidious, means she was more related with cleanliness. She lived in disturbed family due to maniac brother-in-law. So she used to tell me she is living in the family where her husband is good, but brother-in-law is having maniac attacks, and my grandparents are totally conscious of his behavior and they are taking more care of him and neglecting us, and family atmosphere is really disturbed. Now I see all the time they are quarreling, shouting. So I don't want to live in that home also. I want to go out of the home. That was that level of irritability and indifference to family members was developed in her. She was not having any desire to go home if she's going outside. And she developed fear of quarrels. Anxiety, fear, and fear of quarrels was marked in her. So in such family, and at the same time, she is suffering with this vulval pain. So these two things again aggravated the conditions. Her investigation reports, these are just to exclude the pathology, USG, HPV, liquid base. We have to rule out whether she had a human papillomavirus infections, because HPV is most of the time found in association with CS cervix also. This liquid based cytology is also performed for that condition only to rule out any premalignant changes or cervical dysplastic changes at the cervix. Urine routine we have to perform for UTI, and since she gave history of enteric fever frequent and all, I just wanted to check her hemoglobin and WBC counts. So basic investigations performed were already performed March 24. So USG report was normal, nothing abnormal was found. Then a liquid-based cervical cytology again was negative for any HPV infection. Can you see this HPV DNA report? Human papillomavirus DNA, high risk, we can diagnose, but the test was negative. So no human papillomavirus infection, no urine report abnormality. Then serum investigations were performed, follicular stimulating hormones, again that were normal. LH was also normal, FSH 6.8, and follicular phase, mid-cycle phase, it can be till 22, and 22 luteinizing hormones is again within normal limits. Mid-cycle phase, it is normal. So hormonal testings was also normal. Then bacteriological study, it was found that she is negative again for intraepithelial lesions. This is liquid-based cytology. This is advanced test which is done in pap smear. Further, after taking pap smear, a liquid-based cytology is done to rule out any cervical dysplastic changes in her ectocervix. What is cervical dysplasia? When endocervical cells replaces the ectocervical cells, stratified squamous cells. When columnar epithelium replaces stratified squamous, the change is metaplastic. It is physiological, so long as it is not giving a atypical cells on histological studies of this pap smear and liquid based. But liquid based also diagnose HPV infection simultaneously. So it is performed in most of the gynecological conditions in reproductive age group of women. Urine report, routine microscopy was normal, just it is positive just for leukocytic infiltration. So just it was in past history she was having infection, so the hazy appearance of urine, but it was it was not so much bothered condition. So far as urine infection is considered acute, in acute stage presently, so it can be considered as normal. So Her hemoglobin was very good, 12.2, not so much change. And thyroid profile test. That is also normal to find out any hypothyroidism changes and all. So all the tests were near about normal. Still, pain was there. So her repertorial totality, ailments from the rubrics which were considered, ailments from discords. Discords here, family members. She is having discoordinations with her family members. She dislikes and the atmosphere of the family. Mind, anxiety, fear with. Mind, company, desire for. She used to tell ki I should leave this home and I want to go in my family members at my mother's place where I used to stay with my joint family, and I am a woman of a family woman. I want that company always. And in this area, at my in-laws place, just we are 4 peoples and they are all continuously quarreling. So no peace of mind in my family. So she desired company of peaceful peoples, cheerful family members she needed actually in that stage. And so she has to live in that family. She is newly married. She was having one child of 1 year only. Husband was so nice. So she wanted to live, but her emotions were suppressed. Ki, I cannot go outside. I cannot meet with outside peoples. In-laws are suppressing me. Matlab, they are not giving me that freedom that I should go outside and so that I will speak about a brother-in-law. So emotions were suppressed and mind was fastidious. I keep my home clean and these people make everything dirty. So that is a constant anxiety in her mind and irritability, fastidiousness. Mind indifference, family to her. So mind uptight, again a rubric which nervousness. Mind weeping alone when. She weeps when she was alone ki kabhi mujhe ye family atmosphere से बाहर निकलने को मिलेगा क्या? That was her sentence when she gave me history in follow-ups. So weeping consolation was there by amelioration, and then mind weeping trifle sad. She started weeping. We can say a mild amount of depression she has developed at this stage. So head pain accompanied by vomiting was taken. Head pain accompanied by gastrointestinal complaints, and stomach hyperchlorhydria, hyperacidity. Rectum, she used to have constipation, insufficient stool. We have seen 3 to 4 times she have to pass. So constipated. Her family, female genital symptoms, female genitalia sex pain, left-sided troubles when I have elicited on examination. Female genitalia sex pain, burning. Female genitalia sex pain, sitting aggravated. And stitching pain in between labia around the vulvovaginal junctions. Female genitalia sex, walking aggravates. So here extremities, heat on her feet, soles, extremities heat, which was a prominent symptom. Generals, food and drinks, desire, sweets. And she was lean people, very lean, thin. I asked to send video, but I think she was not ready to send it. And a repertorial totality revealed rubrics have revealed the remedies were pulsatilla, lycopodium, sepia, sulfur. So looking back to materia medica, after taking all repertory, we have to go back to materia medica. How we can begin? This is showing a symptomatology of 2 drugs, pulsatilla, sulfur, sepia, 2 to 3 drugs. So again, refining this case, the approach, definitely we have to consider on repertory as well as her individual characteristics. Since she was suffering from since 6 months, I have started this case again with sulfur, 204 doses twice in a day for 2 days, and then followed by Saclac for 15 to 20 days. Her first follow-up was on 28th of Jan 24. She then again redefined her symptoms. At this time, after taking her symptoms, no much relief, but okay, general feeling was good. Then ferrum phos, again a biochemic was admitted in gynec practice. We have to, I think, support the biocombinations for getting reactions from vitality. When our one drug is acting, we can give her sense of relief if we are giving ferrum force. Second follow-up was on 22nd of Feb 25. Her complaint were relieved. She was telling that pain is relieved to some extent. She is feeling much better. Her weakness was gone. Most of the weakness, jo debilitated feeling was gone. Her last menstrual period was 9th of February. Her menses were normal at that time. And then normal routine was started. She said, I have started with my normal routine. Now my complaints are aggravated only after menses, after sitting and at night, while I can do my daily routine normally. But anxiety and night, her anxiety was not going, which is not mentioned here. So what is to be done at this stage for her anxiety? She was continuously asking one thing only, kabhi theek hoga kya, can I will get very... So Kali for 6x was advocated in between 22nd February 25. Then after nearly about 15 to 20 days, third follow-up was on 16th of March 20. Sorry, by mistake it is written 24. 24 it is. No? So redness at vulvovaginal junction was found when she actually came in the OPD. Pain was relieved, but redness was there. Hyperacidity was there. Now at this time, I asked her breastfeeding whether she had discontinued or not. She said कि अभी भी discontinue नहीं किया है because no one is there in family to look after. No one is caring to her baby, how to remove. But I told her, now this is important point. Even if our medicine is acting, but maintaining cause was there. She's still feeding her baby. That is causing hormonal imbalance. Most important is estrogen deficiency. So estrogen deficiency was there and this pain was not relieving to that extent. Breastfeeding was continued. At this phase, again, argentum nitricum was given for her hyperacidity because we have already advocated biochemics and no sulfur was given at this place. Her fourth follow-up, irritability was decreased. Urine was normal. Pain again reduced to 2+. Estrogen deficiency due to long-term breastfeeding was again noted. Then pulsatilla was given. Now, her as she was in a tranquil state of mind and her considering her mind, she was suppressed emotions, wanting consolations, weeping and all. Now, this is the point where I have advocated pulsatilla 200 for 3 days. And then she was followed by saccharic because pain was still there. And fifth follow-up on 10th April, again, she gave redness at she gave the history of redness at vulvovaginal junction. It was still there. Pain was on and off. She was having mild leukorrhea and debility associated with typhoid. As she gave me the history of typhoid, frequent typhoid, enteric fever, debility. Now, we can see her miasmatic was syphilis or tubercular miasm. She was lean, thin. 2 to 3 points for considering tubercular miasm were frequent infections and like enteric fever, pelvic infections in ANC, lean, thin, and tendencies to get these syphilitic conditions like piercing and redness. All this thing led me to think of tuberculinum, weekly 1 dose. After all this thing, to bring back the cure by nosodes, we see we have to end it. Most of the time, think of the nosodes to complete the cure when we are not getting 100% relief by our well-chosen remedy. So tuberculinum was given weekly. Then as fifth follow-up was on 10th April. Then on 6th follow-up was on after 20 days. Her vulvodynia pain was relieved during and even after menses, which we were used to get it after menses. Pain was not relieving, but now she gave history. It is relieved during and even after menses. I'm feeling much better. And leukorrhea was occasional. Again, some few traces of pelvic infections were there. So leukorrhea was still there. Sleep was sound. Her irritability decreased to highest level. She was feeling very calm now. Then at this point, pulsatilla 1M was given with few doses of Saclex. SL was continued. In her 7th follow-up, that is on 10th of June, after a long time, she again consulted. So vulvodynial pain decreased to 3+ now. redness discharge was still present on and off, then pulsatilla, tenem 1 dose was prescribed at this point. So this is classical Hahnemannian prescriptions which gave results all the time. So this is my presentation.
Thank you, Doctor.
Thank you.
Excellent presentation. Approaching the case, considering the generals, it's very needed, because otherwise, if you are just prescribing on the local symptoms and just taking medicines, the complaint will again reappear. And after that, it will be very difficult to handle the situation. So you considered everything according to Hahnemannian principles itself, and it's just great. And I think more persons are here. Dr. Dhanesh is going to join. Dr. Dhanesh, please. So you can.
Thank you, Dr. Bindiraj, and congratulations, Dr. JYOTI Kalantri. It's really a very good session indeed, and both the cases were really amazing. But frankly speaking, people used to have a feeling that when treating female cases, we have to choose the female remedy. But entirely different concept was accepted by you, because your concept is entirely different, just like a homeopathy concept, that is the totality. That's why in the first case you choose the right remedy, sulfur, but nobody think that the sulfur is going to act in a lady, but it works wonderfully. In the second case also, you begin with the sulfur and later you have to change it. But frankly, that case seemed to be pulsatile from the very beginning itself. Of course, you can directly go from sulfur to pulsatile, I think, but instead in between you give some other medicines also, or maybe the physician and only mission is to restore the sick back to health. That's what happened in both cases, and congratulations. And no questions. Thank you.
Thank you, Doctor. And we have a chat question in the chat box. Thank you, ma'am. Nice cases. Second case, I want to know the difference between sepia and sulfur. It's from Dr. Namrata.
Sepia and sulfur. I'm not getting the question actually.
Dr. Namrata is here. Let me ask her to unmute and ask the question. She can.
Hello. Good evening, ma'am. Good evening, sir.
Good evening.
Actually, ma'am, I want to ask that you have told in second case you have given a sulfur, but what about the emotions, that is suppression and indifference? That sepia also comes. So I want to know the difference between sepia and sulfur.
Initially, I have started the case with sulfur. See, the pain, we have to desensitize to any patient who is coming to us. See, vulvodynia cases are in so much trouble with pain. We cannot begin with sepia. It is not giving so instant relief with pain. So acute totality we have to consider, as patient was not so having long chronic disease. It was not chronic disease. No, she has been suffering with 5 to 6 months only. So her pain we have to allay first, and her lean thin this thing and her ambithermals and most of the symptoms were matching, and repertorial rubric also gave sulfur first. And for acute cases we can begin with sulfur. If sulfur has done some work, then we can shift it to pulsatilla. Sepia have got changeability and depression stage is very long lasting, and a higher level ka depression is there in sepia, no? So she is having very much hypochondriacs and severities. This is case we can say mild nervousness and depression was there. So we can handle it with pulsatilla only, and this that came at third or fourth stage of repertorial totality. If you have seen, sulfur, then sepia, and then pulsatilla was there. And her disposition was so yielding, so gentle. She used to complain all this thing, but with very much mildness. Itni sari taklifi thi. I asked her to send video, but sometime if she will share, I'll definitely share on my channel. I have my YouTube channel. So there you can see
Welcome.
she
And
was
it's very
perfectly
clear.
fitting for pulsatilla. Yeah,
Thank you, ma'am. Thank you. And
thank you.
we are all delighted, and it was a great day on this Doctor's Day itself. We got a great session. And on behalf of IFPH, I thank you. And I thank all the participants joined here for the session. And it's time to start the Malayalam session. So we are winding up. Again, you please come again, ma'am, in this forum, and that we can have another session on different subjects itself. Thank you.